Yeah, Dr. Miraglia has asked us to not record slides, and frankly, I would ask that everybody not record anything video-wise for the entire conference. We will be recording it. The cameras are up back there. They will be editing everything and then being able to send out email links to you all with the information to be able to access those presentations at a later date. Usually it takes about 2 to 3 weeks to get everything finished up. All right? Our first presenter graduated from SUNY Buffalo School of Dental Medicine. He has 26 years general practice experience in Mount Kisco, New York, including 16 years of interceptive orthodontic experience, where his focus has been on early childhood growth and development. He lectures nationally on childhood sleep disordered breathing and its impact on early childhood growth and development. He holds faculty positions, or held faculty positions, I just found out, with Align Technology, and is on the board of directors of the American Academy of Physiological Medicine and Dentistry. He is on the President's Council of Northern Westchester Hospital in Mount Kisco, New York, and he is recognized as a leader in continuing education by Dentistry Today magazine pretty much since 2015. So please give a warm New Orleans welcome to Dr. Ben Miraglia.
So I'm here to talk to you about Airway Dentistry. I am a general dentist. It is my 29th year in general dentistry. I have been doing growth and development techniques for the last 18, going on 19 years. So I basically call what I do growth and development. And so you're going to get a big dose of it. It's going to move along quickly because in 1 hour I want you to see a variety of things we do from the age of 4 all the way to any adult age. And then you'll get a good kind of grasp of before and after, as opposed to teaching you how to do it. We can't teach how to do something in an hour. So you'll see some nice photographs. About the photographs, I'm going to show you children, and we're going to cover their sensitive medical histories, including medications and symptoms like bedwetting, and things like that are tough. And then some of these kids have school credentials that aren't so nice either at the beginning, and some of these children look very unhealthy at the beginning. So like the good Dr. Green introduced us with the no cameras, no videos. I would appreciate if we protect the HIPAA and the privacy of the children. No photos and videos of the kids you're about to see, because they look very unhealthy at the beginning and they have some significant medical histories that we're trying to protect. So careful with the cameras. It would be very nice if we didn't record anything. So what airway dentistry means to me, it's about growth and development. So we're going to talk about growth and development. Here's the reason I'm here. I think this is why you're all here. For the growth, development, health, and longevity of our patients. It doesn't matter what age, as long as you can intervene and help them out, you can probably make them go from unhealthy to healthy. So it turns out that a lot of the unhealthy comes out of the dental aspect of things, the jaws. Jaw growth and development is the key to being a healthy human being. And so to get started, we're going to cover children at the age of 4. How about in the behavior category? It's one of the biggest symptoms that shows up, ADHD. We see a lot of kids with ADHD, either diagnosed and on medication, or diagnosed and getting ready to go on medication, or have been on medication for a long time. Incredible, right? Attention issues are significantly present in our children population. We ask a lot of questions about that. Teeth grinding. Very common. So parents come in, they tell us right away, oh, they grind their teeth crazy all night long. So we hear that a lot. It's a symptom, and so it's part of the symptom list that we find. Mouth breathing is quite a common symptom too. So this child has these kind of 4 ingredients as their top symptoms: behavior, attention, teeth grinding, and mouth breathing, and here's how he looks. So we meet a child like this, and if they're 4 years old, you can see from the look in his eyes, he will bounce off the walls. So this is a ball of energy. You are looking at a ball of energy. So this little guy's a ball of energy, but what he has inside is what we would be diagnosing as underdeveloped jaws. We don't see the bottom teeth, so he's got a deeper bite. We might call it a deeper bite in dentistry, but chances are that lower jaw is a little bit further back than it should be when you don't see the bottom teeth. So when we take a look at this picture, it gives you a clear view of how unhealthy he is. Now, the dental community should recognize this photograph as an unhealthy child. Everyone in the dental community should know they see a child like that, that kind of profile comes with unhealthy. We don't meet children who look like this and are healthy, meaning totally asymptomatic. So this is a child who will have all kinds of symptoms. Now, of course, over time, we'll be treating him with a variety of techniques. So I am not a subscriber to one technique or one company. I teach in this space across almost all of them. But the idea is when you're incorporating things like nasal hygiene, so that you could have a clean nose to breathe through, growth and development appliances, which there are various in the fixed and removable category, myofunctional therapy, which is a huge help for these kids, frenum releases when indicated, all of a sudden you have a nice mixture of things that you can do to grow and develop a child. So what you're looking at here is a change from about 4 to 7 or 8 years old. So from 4 to 7 or 8 years old, we're heading in the right direction. His jaw is growing wider and forward. And the new permanent front teeth are coming in nice and straight and well aligned. But from 4 to 7 or 8, his facial structure will change, and all of a sudden you'll see the growth of the jaws wider in this particular picture, but will get forward in this particular picture. So here you're looking at someone who is treated with removable techniques, nothing fixed. When I have a case where I used an expander that was fixed, I'll just tell you that I used an expander that was fixed. So this is a removable process, meaning this child would have nasal hygiene, frenum revisions as needed, myofunctional therapy, and I like to loosely use the word guidance appliance type therapy. Removable guidance appliances can redirect a child's growth and development so that they no longer have a sleeping issue. Because if you have a breathing and sleeping issue, you tend to have behavioral issues during the day. We learned a lot of that from Dr. Karen Bonnick. So Dr. Karen Bonnick made a connection between the sleeping and the behavior. So if you have sleep disorder breathing, which is generic, you don't have to have an OSA diagnosis, sleep disorder breathing will lead you to attention and behavioral issues during the day. Well, how do you have a sleep disorder breathing condition? Trouble breathing through the nose. How do you have trouble breathing through the nose? Underdeveloped jaw structure. If the maxilla is too small, you struggle to breathe through your nose, your mouth opens. Your lips will separate to breathe through the mouth. And once a child begins to breathe through their mouth, they're unhealthy, and it will fragment their sleep and produce the symptoms downstream. So this particular child, within months of beginning treatment, when you have the jaw growth and development happening and you have frenum release and or myofunctional therapy and or guidance appliance, you begin to breathe through your nose better. When you breathe through your nose, you sleep better. When you sleep better, you are a different child during the day. So his attention, his behavior, all come back to what would be considered normal. And then, most importantly, at the end of this, usually around 7 or 8 years old, you'd recognize that he doesn't grind his teeth anymore. When you have enough growth and development to catch up to norms where you should be at your age, you stop grinding your teeth. So we could lose that symptom as well. So this represents a lot wider and forward growth done as naturally as possible without anything fixed in the child's mouth. Now, the cases will get worse as we go. Night terrors is a very significant symptom, and we meet a lot of children who struggle in the night terror or nightmare category. It usually leads to anxiety. These two are paired. Given enough time, the night terror will become an anxiety issue. So we meet this nice child at age 9. This is not a healthy child. If you look at a photograph of children who look like this, she's struggling. This is a 9-year-old who's struggling. So what happens to her is this. The night terrors begin at age 2. 7 years continuous, the night terrors, almost every night of the week. So when you wake up in the middle of the night with a night terror, you have trouble getting back to sleep. But then as the years are going by, what happens is the child will now fight going to sleep because they know what happens when they go to sleep. So the bedtime graduates to 8 o'clock, then 9 o'clock, then 10 o'clock, then 11 o'clock, then 12 o'clock. Now, by the time we meet her at 9, she can't fall asleep till after midnight because she fights it. So they're up until after midnight. She knows if she goes to bed, what happens to her? She doesn't want to go to sleep. So this difficulty falling asleep translates into the anxiety issue is growing because now you have someone who has a full-blown anxiety condition. The medical community has evaluated her. She's seen over a dozen specialists before getting to us. All of her disciplines all across the country. They took her everywhere, and they all had a similar recommendation, medication. We can try this medication. We could try that medication. We could try, and she was offered pretty much everything. In every category you could think of, an attempt to medicate. But the parents didn't agree with medicating this problem. They were still looking for an answer. So here we are, we get to 9 years old. Well, the most significant part of her diagnosis was the frenum restriction. So she was tongue-tied. So she has a frenum restriction that prevents the tongue from elevating. If the tongue can't elevate, then it can't seal. You cannot have a vacuum swallow. If you cannot have a seal in a vacuum swallow, you will swallow air. When you're swallowing air, it will throw off your entire system. So she's been mouth breathing and worse for the 7 or 8 years continuously. And all we had to do was redirect the tongue. So nasal hygiene, frenum revisions, removable guidance appliances to work with, and of course, the myofunctional therapy as a big aid to retrain and re-educate that tongue once it's free. Just freeing the tongue doesn't do the job. You now have to train it where to go and what to do. This is 6 months of progress. In 6 months, she transitions from night terrors to dreams. Now the child goes to bed at a normal time, has a dream which she will describe as being the entire night, and then she wakes up in the morning. So at the 6-month mark, she no longer wakes in the middle of the night, no longer has a nightmare or a night terror, sleeps through the night, loses the anxiety issue, doesn't need medication. By the time we're 11, this is 2 years night terror free. Now, we haven't done anything fixed. No expanders, no brackets, no wires. I'll show you those when they're in there. This is all removable. Nasal hygiene, frenum release, myofunctional therapy, guidance appliance. All of these things can transition that deep bite class 2 retrognathic jaw position to a full, beautiful, as we say, class 1 in the teeth. But meanwhile, all of the teeth are migrating where they belong because you've redirected the breathing and musculature. If you redirect the breathing and musculature to do its job, that's how the teeth end up going where you belong. The teeth are a symptom, so we don't treat the teeth. I do not treat the teeth. I treat the jaw growth and development to restore the nasal breathing, to restore the proper muscle function and balance, so the child will grow on their own as naturally as possible. Of course, we're going to get to age 13. This is 4 years night terror free. What began as, you would see, that deep bite class 2-ish became a beautiful type-it-on style type 1, so the teeth are there without having braces ever. This child doesn't need braces, will not get braces, has a beautiful broad wide arch, has a beautiful home for the tongue. She breathes through her nose, she sleeps through the night, and she has had 4 years night terror free. That's age 13, but she's now 16. So this is now a 16-year-old that hasn't had a night terror since she was 9. How about this list? It'll get worse as we go. There's a cognitive development issue here. Mouth breathing, sleep disorder breathing, referred by her pediatrician. We began this a long time ago, 18 years ago. I started doing this, and then I started about 2 years in doing lunch and learns with the local pediatricians, so I could get in front of them to show them you can treat a child early, and help them out. You don't have to wait till they're 9, 10, 11, 12 and suffering. So if you send them a little bit earlier, we might be able to help. So sure enough, that led to grand rounds. I started doing grand rounds quarterly for all the pediatricians. That was 25 of them. I had 25 pediatricians in front of me quarterly on a Tuesday morning at the hospital. And then we did that for a very long time until they all understood they need to send a child to someone who wants to do growth and development, not someone who wants to fix their teeth when they're 13 or 12, because fixing the teeth at 12 doesn't heal a child. So yeah, there's a thumb habit in the middle of that early on, and then this child is struggling. And this is the photograph of a child who is struggling in every direction. This is not a healthy child. If you're 9 years old, you have been struggling for 6 years, maybe 7. So here we are, unhealthy. Lips are dry, cracked, all the signs of mouth breathing. There's no lip seal at rest, of course, so we have a mouth breather almost 24/7 here. So this child is struggling in every direction: school, social, emotional, at home, cognitive, having trouble keeping up, narrow. There's some overjet. There are the printed models for you. If you don't see overjet, just squint a little, it'll show up. Just pretend. You could pretend for us. It's 10 millimeters of overjet. Of course, narrow and vaulted, no room for the tongue, and a frenum that's too tight. It turns out 18 years ago, you would ask me, hey, what about the lingual frenum? I'd say, what's that? What do you mean tongue tie? Ankylogloss, what? That's 18 years ago. Now today, I can tell you with confidence, most children have tongue restriction. Most do. It's overwhelming. And when you start to do assessments appropriately, Dr. Markazan, Dr. Zaghi, Dr. Kotlow, you got a list of people out there teaching how do you assess it to be quantitative and definitive in a diagnosis rather than just guessing. Most children are tongue-tied or restricted. And a restricted tongue delivers a lack of or less growth and development. And less growth and development is your risk factor for sleep disorder breathing. So they're all tied together. Of course, we're going to release that. Now, this child did have fixed expanders for 6 months. Fixed expanders for 6 months, then we get them out of there. So nasal hygiene, frenum release, myofunctional therapy, fixed expanders for 6 months, transition to removable type guidance appliances. So now there's nothing in there. This is progress. Now in that amount of time, most of the symptoms fade away. This is the difference, and this is about 1 year later. So now we're turning 11, and we have all of these teeth where they belong. Big, wide palate for the tongue. That's where the tongue lives, up there. And then, of course, the lower. Big, broad arch. So this child will never see a set of braces as a teenager. You have a beautiful bite. If you address the foundation, the maxilla and the mandible, you grow the foundation, the teeth will coordinate themselves almost on their own. It's amazing how they'll go when you balance the breathing and musculature. And next thing you know, it'll change your facial structure. So we're saying after, but meanwhile, you're looking at from 9 to 11. So when you have like an 11-year-old on the right side of the screen that now has lip seal, breathes through her nose, sleeps through the night, no longer struggles in school. The equivalent of what you would say is that straight A student. It's done differently today, but she's no longer struggling in school. And now, of course, you have this change, but you also have a full broad smile where you can see every tooth all the way to the molars. The tongue has a beautiful home. The tongue would be very happy to have a mansion to live in. And then you have the profile the child is growing not only wider but forward, including the upper arch. We don't pull the upper back. When you have 10 millimeters of overjet, it just means that the upper is retruded. 10 millimeters of overjet, the upper was retruded. Wrap your head around that. The lower was severely retruded. That's a perspective issue. No child walks in with a class 2 and has an upper jaw that's too far forward. That doesn't exist. I'm going to show you the next child, and then we'll look at some x-rays to prove it. They both need to go forward. Just one has to travel more than the other. We don't pull things backward. How about this list? Enuresis is just a fancy word for bedwetting. It's 5 nights out of 7, and we're almost 10 years old. Snoring, apnea, sleep disorder breathing. Adenoids were removed when he was 6. Cognitive developmental issues. He did the 3rd grade twice. After 4th grade, he was told, we're going to put him in 5th grade, but we don't think he'll make it through the 5th grade. Plan for a tutor across the board in everything, or he does 5th grade twice. Imagine that, sitting in that meeting after you've done 3rd grade twice, you're going to get pushed into 4th, you're going to get pushed from 4th to 5th, and maybe have to do 5th grade twice. That's incredible. Turns out he's also just finished with 15 months of phase 1 ortho, somewhere else, of course, not in my hands. So someone else did phase 1 ortho, but we're going to look at this because they attended to his teeth. So it's a whole different ballgame if you're focusing on the teeth versus focusing on the foundation. This is that child at 9.5. Now this is my photograph, so it's my before photograph, but of course.
Sorry, I'm going to switch you out. I apologize.
Better? Better, better, better? No? No. I'm just going to eat at you like you're my kids. So I just bring it up. What? Why are you doing that? Make your bed. Feed the dog. Walk the dog. I feel like I'm back at home. Are we good now? Okay. Terrific. Three teenagers at the same time. Take that. That's why I'm down here. Tired of getting told what to do, and I'm wrong. This is easy here. All right, so back to this little guy here. This is the look of unhealthy and struggling. This poor kid is struggling and has been for a long time. His problem didn't start yesterday. He's been struggling for about 7 years. So sure enough, he looks like this. Meanwhile, my before photo. But because he just finished 15 months of phase 1 ortho somewhere else, this is somebody's after photograph. This is somebody's after. Someone has to stand here and say, well, 15 months ago he looked like this, but now he looks like this. This is a result in someone else's hands. So we'll keep track of that as we look. This is the photo of my before picture, the day we meet him, but he just finished 15 months of phase 1 ortho. This is what you look like when the attention is on the teeth. It's not a tooth problem. It's a jaw growth problem. And this is what you look like when you have 15 months. I think I broke my 3rd. Post phase 1 ortho right here. There you go. Another 8 to 10 millimeters of overjet here. And so, of course, this is where no child belongs at this age, right? And look at this result. V-shaped, high vault, no room for the tongue. Ortho. And this is what's in there. Lock in that lingual control arch to protect.
So sorry.
Oh, wait. Oh, we've got another one. What are we going to do for the rest of the speakers? Just trying to turn the TV on.
You know what? Do you have a front pocket?
Never mind. I don't want to watch Bachelorette.
Do you have a front pocket on that?
A front pocket? Oh, here. Is it a clip? I'll take it.
Yeah, it just has to be real towards the front because of that thing.
How about that?
Let's try that.
We're good. Nice. I'm back. Woohoo! All right. So, this is a lingual control arch. I don't refer to it as that. I just tell you what you know it's called. I call it a jaw binding appliance. This is not where that child belongs, yet we're going to freeze him there. Wrap your head around what that's doing. He's 9.5. He's not as big as he should be. He's underdeveloped, but let's freeze him there. Why don't you give him one size sneaker and say, wear that for the next 10 years? That's locking someone. Now, you recognize the camouflage technique, right? Take out the lower primary cuspid so the front four incisors can line up better. Camouflage, that's a subtractive technique. You know on the bottom he's got four incisors. Where's the canine going to go? So they take out the primary canine so the four teeth line up, and they've made an improvement. This is a subtractive technique. I wonder what's next for this poor kid. Well, let me show you how he's struggling, because when he gets to the myofunctional therapist and we start doing recordings of what he can do, he can't say the alphabet without making mistakes. He's 9.5 years old. He's done the 3rd grade twice. He's about to do the 5th grade twice. This is his best attempt at the alphabet. He's given 10 tries, by the way. The mistakes are ranging from 2 through 6. Here he is trying to say the alphabet.
A, B, C, D, E, F, G, H, I, J, K, L, M, O, P, Q, R, S, T, U, V, W, X, Y, and Z.
And that's why he's struggling. Now you can see why he's struggling. So by now, everyone in the audience has heard the word airway. It's just a space, but it's dentistry's favorite word. It's a space. It's an empty space, your airway. Well, to be more professional, we could say the nasal cavity, then the nasopharynx, then the oropharynx, then the laryngopharynx. Those are those 4 regions. If your maxilla is narrow, you have a compromised nasal cavity. Then on the profile photograph or x-ray you have here, here is your nasopharynx above the soft palate. Here's your oropharynx at the level of the mouth, and then your laryngopharynx. So he has the equivalent of a coffee stirring straw. You know the ones in the other room? There was a cup of black straws next to the coffee. It's a little tiny coffee straw. That's what he's breathing through. This gentleman has one right here. So just imagine plugging your nose, putting that in your mouth, and that's all you could breathe through. Put that coffee straw in your mouth, take your cotton roll to practice, plug your nose, see how long you could last. He's done it now for 9.5 years. 9.5 years. You won't want to go 9 minutes. Unbelievable. So now, before, in the previous patient, I told you there was 10 millimeters of overjet. What way did we go? Forward, including the upper. This is the reason you do not pull the upper back. His upper jaw is retruded. When we meet these children who have a class 2 bite, it doesn't matter where the upper is in this, it's too far back. You don't want to pull anything back anymore. You need to be going forward. Just because the upper goes forward doesn't mean the lower is going to be a tragedy. You need to get that forward too, because he's going to finish class 1. Ready for this? Without using a single elastic. I don't use elastics. Class 2 elastics don't pull the lower forward. They pull the upper backward. So we don't use class 2 elastics. I have no interest in pulling anything backward. He can't breathe as it is. So we take a look at this, and don't forget, that's my before, but that's his lower bar in there. That is his image after 15 months of phase 1 ortho, where the attention was on the teeth. So you just saw what attention to the teeth can deliver children. What if we do the opposite of this? Now we're looking at these 2 pictures just because you've got this lower lingual control arch holding that result, and you've got that almost 10 millimeters of overjet. And guess what phase 2 was going to be before he met us? Because they had a plan. 4 by extraction. See, the upper 2 have to come out because of the overjet. That's how you close the overjet. The lower 2 have to come out because there's no room for teeth in the lower arch. So this is a 4 by extraction in phase 2 if he doesn't meet us. Tragically, I meet a lot of children after the teeth are out. Him we met before. They wanted another opinion. So we met him. We'll go and do something different. Let's do something different. How about we focus on the foundation instead of the teeth? How about we focus on the breathing and sleeping? How about we focus on the tongue? In other words, why don't we do the opposite? Why don't we ignore the teeth? Let's do the opposite of just what happened there. Should work out. This is 10 months later. Now in 10 months, of course, fixed expanders first. He's so far behind and so struggling, fixed expanders for about 6 months. Get that opened up. When I say fixed expanders, I mean 10 millimeters wider, both upper and lower. So I use a pair of expanders, upper and lower. When you use fixed expanders, you need both. Upper and lower fixed expanders will get you 10 millimeters or more. Some kids need 12, 16, 20. Doesn't matter. You have to start somewhere and get them where they need to be. So in 10 months' time, we can get the foundation growing where it belongs, and all of a sudden the overjet's almost completely gone without a single elastic. In just 10 months, he goes from struggling to thriving. He can close his mouth. He has his lip seal. He's breathing through his nose, but he still has hyperactive muscles in his face, and you can see it. He's not done yet, but he's working hard with that myofunctional therapist. So she puts him through boot camp style training. But the jaw growth is wider and forward, including the upper. So wider and forward. Here his face is going to start filling out. And in just 10 months' time, that tube starts to open. So now what you can recognize here is that this is the coffee stirring straw, and 10 months later, we start opening that up because both jaws are going forward. That space is created by where your jaw growth and development is. If your jaws don't grow wide and forward, you get a tiny space to breathe through. If your jaws grow wide and forward, you get a big chamber here for air. So in 10 months' time, the overjet is decreasing as both jaws are going forward. So we're guiding his growth and development wider and forward. So did he have nasal hygiene? Sure. Myofunctional therapy? At least a year of it. Frenum revisions? Sure. Fixed expanders followed by removable guidance style appliances. And the change in 10 months' time. Now the waking every night and the bedwetting stops at about 8 weeks. Anywhere between 2 and 8 weeks, usually the bedwetting goes away and the waking in the middle of the night goes away. The night sweats and night terrors can take a little bit more, but they fade, and children will tell you, I'm dreaming. I have dreams now. I never had dreams. I don't think I ever had dreams. I'd always have nightmares. I can't believe I'm dreaming. Silent nose breathing and that alphabet. He couldn't say the alphabet. His best attempt was 2 mistakes. The worst was 6 in 10 tries. After all of this progress in 10 months, he's reading the Harry Potter series out loud to his mom. That's their bedtime routine. So now he can read the Harry Potter series. He won't have trouble in school anymore. By 15 months of progress, you can see the change in the teeth a little bit, but now the overjet's almost gone, and we have a mild amount of crowding or displacement of teeth in a class 1 bite. And all of a sudden, we have a big difference. In 15 months of jaw growth and development, focus and attention on the bones, not the teeth, you have a much bigger home for the tongue, so wider and forward. And all of a sudden, you have this change. So he goes from someone who was going to have the upper bicuspids taken out to close the overjet and have the lower bicuspids taken out because there's no room, to having everybody show up and be present with a mild amount of crowding that we could probably just align with a few clear aligners, which is our phase 2. But meanwhile, we have a full transition from unhealthy to healthy. So not only is he equivalent of an A student in school, but he rejoins a basketball team he was asked to leave because he couldn't attend to being on the court when he was supposed to be. He was asked to leave the basketball team because when the coach recognizes, hey, where's Christopher? Where'd he go? Oh, no, he walked away. He's not on the court anymore. He'd be in the stands. He'd walk around. He'd leave the building. We can't have you here. We need 5 people playing basketball, not 4. He got kicked off the basketball team thanks to his attention issue. Well, all of a sudden, he rejoins the basketball team, joins the soccer team, then he joins the band. He plays drums in the school band. So phase 2, instead of being 4 bicuspid extraction and full retraction of this child into an OSA patient for life struggling, we just made him a few clear aligners to finish lining up his teeth. No elastics. Full jaw growth and development, wider and forward. Myofunctional therapy is probably the biggest part of his treatment. And sure enough, we get to maybe he's 15 here. Well, hello, Christopher. How about that haircut? Nice. Well, I knew you were here because I smelled the Axe cologne from the parking lot. You know you don't have to use the whole bottle. Half is enough, you know. I've got one at home just like that. You open the doors differently when they're a teenager and they find the Axe cologne. You kick the door open, you back up a few steps, just because if you step in that room after that Axe has been sprayed like that, you'll collapse. And then you'll find yourself crawling to the window trying to breathe. Here he is in 2021, and what you'll recognize now at age 17, his wisdom teeth are erupting into function. So since I'm in this 18 years, most of the children I treat keep their wisdom teeth, and they erupt without help. They erupt into function. We're at 70% now. So 7 out of 10 children that we treat erupt their wisdom teeth into function. He would have had 24 teeth. He would have had 24 teeth in his mouth and been a disaster forever. Now he's got 32. But meanwhile, those 32 teeth have a beautiful home for the tongue, a nice class 1 bite if you have to see a beautiful class 1 connected set of teeth, which is the least important thing. The jaw growth is the most important thing. But meanwhile, you've got a kid who varsity basketball, varsity soccer, straight A student, drummer in the school band. Limitless. He can do whatever he wants because he can sleep and breathe. How about this one? Chronic mouth breathing and snoring in the history, nasal congestion, multiple ear infections and tubes, crazy common that is. trouble falling asleep, waking every night, morning issues, school struggles, fatigue, has a diagnosis already of mild obstructive sleep apnea, has ADHD as a diagnosis, is already medicated. Some of these kids walk in and have already started their medication. And we meet a child like this, struggling at age 10, and medicated already. Well, her teeth look okay. At a first glance, her teeth look okay. Almost looks like she has a little bit of forward growth there. We could check out underneath. She does have forward growth there. Not the worst tube you've ever seen, right? Look at this tube. Big. That's a garden hose. Plenty of room there. So if it's not the forward component, well, then we must be narrow. So we'll check out that in a second. Look at these teeth, right? She doesn't need anything, does she? Except she can't sleep and breathe. Well, too narrow. How do you show too narrow? Well, you think about transverse measurement. I threw TM up there. The transverse measurement is the distance between the upper first molars. She happens to be 33. 33 millimeters. Now, to put it in perspective, she's supposed to be 40. 40, because eventually you should get to 45. See, a human being that wants to have all 32 teeth erupt into function needs a minimum of 45 millimeters between those teeth. And that just provides for about half of the wisdom teeth. Half. You want all of the wisdom teeth, meaning 95% of the wisdom teeth erupt into function? That distance should be 50. How do you know this? Anthropology research. There's a point in time where anthropology research shows how the jaws were growing, how big they were, and everybody got 32 teeth in a big wide arch. That's because the maxillomandible grew fully. But the moment you have a change in your lifestyle where the jaws don't grow as much, then you can mark, well, where does the wisdom tooth extraction rate start popping up? And it turns out with industrial Western living, the early soft diet triggers your muscle dysfunction and weakness, which doesn't grow your jawbones. And next thing you know, when the bones don't grow, you have teeth that don't fit. Crowded teeth are a symptom of underdeveloped jaws, but the cause of the underdeveloped jaws is the weak and dysfunctional musculature, and it's created by the early soft diet. So, the early soft diet delivers the weak and dysfunctional musculature, delivers the underdeveloped jaws, delivers the crowded teeth, or bad bite. And next thing you know, you can show with every single area of the world where industrial Western lifestyle changes to an early soft diet between 0 and 2 years old, the jaw growth and development shrinks, and the teeth don't fit. So this child is 33 millimeters, and 40 would be the minimum. So we'll put her in expanders. Here's a picture of them, just so you see them. It's a generic expander. We're not marketing or infomercialing anything today. But an expander to give 8 millimeters, get her to 41. 8 millimeters, line up the teeth, and then, of course, when you get to 41, we start talking about symptom reduction. Because as soon as we start talking about her symptoms are fading away, if your symptoms are fading away, if you breathe through your nose and you sleep through the night and you wake up refreshed, you probably don't need to be medicated. So we start talking about symptom relief because 8 millimeters upper and lower expansion is significant. Now all of a sudden we've got a nose breather on our hands. Well, a week after bringing up to the dad that we could probably talk to your physician about reducing that medication, they call back and they say, interesting that you mentioned to me about medication reduction because this morning Molly said she's feeling better and doesn't think she needs the medicine. What do you think a 10-year-old is thinking when they're taking medication? They're broken. They think they're broken. They think there's something wrong with them. So a child taking a medication when most kids aren't, because a percentage of them are, feels like there's something wrong with them. They feel broken, they feel damaged, they feel less than. It's an incredible dynamic. She doesn't want to be on it, but she starts feeling better and she knows, maybe this will be my path. So we talk to the MD. Prescription medication reduction begins. Don't forget, those are amphetamines. Those are heavy hitters. Nobody stops taking those. You have to be weaned off of those. It takes 3 months minimum. And for most kids that we're seeing with the crazy levels they're on, 6 months. 6 months. This was a 3-month run. 3 months later, because we all have kids same age, we're at the college fair night at the high school. And so we're walking around and we're looking at the college fair night because our older kids are in there, and this happens to be a friend of the family, so I know. And I hear my name, because, you know, when you're at the fair night, you don't want to hear your name. Dr. Miraglia, Dr. Miraglia, Dr. Miraglia. And you're walking around, you're walking faster, and you're trying to get away, and your wife is saying, why are you running at the college fair night? And your kid's like, what's Dad doing now? He's going to embarrass us again. And I'm trying to get away, because I don't want to talk to you at college fair night about your chipped tooth. I think I chipped a tooth on the cookie they had out there. It's like, come on. It's college fair night. At least assault me in the parking lot after it. All right, so her mom is running down trying to catch me. So she's faster than me, so she catches up to me in the middle of college fair night. And sure enough, it was just to say thank you. It was just to say thank you because Molly's now off all the medication. That day was the last day. So no more medication. And kids who have attention and struggles at school, they get pulled out of class. Her school happens to call it small group. Not such a good word. You're small. So every morning at the beginning of school, the 4 kids are called out to go to small group. How's that feel? You 4 stand up and walk out of the room and go to small group. How's that go? How's that feel when you're 10? Awful. So she was in small group. Well, 3 months later here, off medication, going back into regular class. No more small group. So she's back in full class, and she's not struggling in math. Now she's bragging, math is easy for me. Amazing what you can do when you sleep through the night, nose breathing. So here she is, before, and now at age 15. So our treatment was all of 10 months. I treated her for 10 months. We put in expanders, we lined up her teeth, we took them away. They're in and out quickly. So myofunctional therapy, frenum revisions, nasal breathing and hygiene, get that child caught up to 41 millimeters so she can keep growing. Now you're looking at someone who's got a broad, wide palate. Look at the room for the tongue. Never mind how well aligned the teeth are. What does the tongue think of those 2 pictures? Big, broad, wide arch. You could make a few aligners if you want. I see the crisis in the lower front teeth. I see that crisis of crowding. I know that's so awful to leave a child like that. I'll make her 5 aligners one day, don't worry. Age 15, normal functioning. From the time she turned 11, she's been off medication. She's 4 years medication-free, sleeps through the night, has no symptoms. How about malocclusion, TMD, headaches, sleep disorder breathing in a teenager? What if their kids are getting older? Well, this happens to be a struggling child also. Look at the face. Now, the single biggest issue here is the headaches. So this child has serious headaches. All right. Now, at age 16, she completed 4 years in braces. You'll see the results of the 4 years in braces. But then attention to the teeth. So she ends up at the TMD office. Here's the history. Braces for 4 years. Her TMD pain and headaches begin during the ortho. She never had a TMD or headache in her life up until the braces went on. Shortly after the braces go in, the TMD and the headaches start. Jaw clicking, jaw popping. Her braces were removed just prior to 15 years old, 11 to 15 in braces. At age 16, she gets to the TMD specialist because her jaw pain and her headaches are significant. And from 16 to about 19, they do 3 years of monitoring and maintenance with splint orthopedic type appliances to reduce her symptoms, not eliminate them, reduce them. Now, a teenager using those appliances day and night can have some sort of symptomatic relief. But this is the result of the 4 years in braces attending to the teeth. That's an after photograph. That's my before picture, but that is somebody's after photograph. Somebody should have to stand here and say, yes, I just completed 4 years in braces. Look at this. That's what's out there. So here she is. Wonderful, right? Same as always. It's not about the teeth. It's about the jaw growth and development. The transverse measurement here happens to be 27. Do you know when 27 is appropriate? Never. Because a 4-year-old is supposed to be 30 minimum. That's A and J. When you're 4 years old, A and J should be 30 millimeters apart. That's the bottom line minimum for normal jaw growth and development. We don't see that very often. Here's a now 19-year-old showing up at 27. It should be no surprise that you're having headaches and TMD problems. All right, so the TMD gets us some information. Jaw pain on opening, pain when chewing, decreased range of motion, intermittent jaw locking. The frontal headaches weekly were a disaster for her. Jaw clicking and popping, anterior disc displacements. It's the headaches that took her out of college. She went to college, she got through freshman year, beginning of sophomore year at age 19. She couldn't take the headaches anymore, couldn't participate in classes anymore. Struggling student, came home. Came home and ended up in our office. So we met her at 19. So at 19, what we did was, 19, the bone's a little more mature, so I don't use the fixed expanders that much at age 19. Removable. I used removable adult expansion style appliances to grow that maxilla. Now what you're looking at on the right side of the screen, teeth 7 and 10 do have composite buildups because they were smaller. If you look at the left side, you'll see that teeth 7 and 10 are undersized. 10 is even like a microdont type tooth. So I put composite on 7 and 10 to make sure they had the right width. The rest of her teeth are just a result of having some whitening gel in the aligners. So what we did was first removable adult expansion appliance style appliances to grow the maxilla, and then clear aligners to finish coordinating the teeth. And in the clear aligners, you throw the whitening gel, so of course the shade difference. But the only two teeth that had dentistry were the two laterals. So now 27 goes to 37. This is a 10 millimeter change. The first 7 millimeters are by the removable adult expansion appliance, and the next 3 are from the clear aligners. So now you have a 37 millimeter transverse width, and the tongue loves that. Look at the difference for the tongue. And the lower wasn't as bad. The upper was more collapsed than the lower, but the lower still needed alignment and uprighting. So you move those teeth away from the tongue, give it a bigger home. Meanwhile, you land with a beautiful occlusion and a bite. That's an incredibly appealing smile. But the result here is, again, 7 and 10 have composite. The rest of the teeth, it's whitening gel. You grow the maxilla, the mandible can land appropriately, and you have a patient that about 6 months into treatment had her last headache, which was 5 years ago. This is now a 26-year-old who went back to college, finished her degree, got her master's, and now is an elementary school teacher. Hasn't had a headache in 5.5 years. Not one. And we ask every time she comes in, have you had a headache? Nope. You have any TMD symptoms? Nope. We're not afraid to ask because we know we solve those problems. Look at the difference from struggling to healthy. From struggling to healthy. All about the jaw growth and development. You can see how narrow and almost deformed her smile was at the beginning, and now you've got someone who has a fully grown maxilla, a well-positioned mandible, and well-aligned teeth. How about malocclusion, sleep disorder breathing, TMD, facial pain? Let's get older. Let's look at an old man, right? He's younger than me, so I can say that. All right, look at this guy. Now he should be thriving. This is not the picture of healthy. This guy's struggling. So here he is struggling. He's got his lips apart, he's breathing through, but mostly his issues are with the TMD and the facial pain. Look at this bite. Edge to edge, he can't get his back teeth to touch. He'll tell us that in a minute. We'll get his chief complaint. So of course he's underdeveloped. It's not about the teeth, it's about the jaw. So here he is trying to smile, and there he is in his profile. It's horrific. And he's struggling. Uh-oh, he doesn't have any crowding. He's edge to edge with no crowding, and by my diagnosis, has maxillary deficiency. I wonder what's going to happen when we grow that upper jaw. Probably get some space somewhere. If the list of symptoms is significant and you want that upper jaw to be grown, go where it belongs, next thing you know, you're going to have to watch what the mandible does. See, the more narrow the upper is, the more trapped the mandible is. Just because he's edge to edge and it looks like his mandible is ahead of the maxilla doesn't mean the mandible's too far forward. In fact, his mandible's trapped back. As soon as we start moving the upper and widening it, that mandible is going to slide forward and release, and that will take away all of the TMD and facial pain that he's having. So look at this terrible bite. He can't get his back teeth together because his front teeth crash. He goes to the TMD specialist first for a full evaluation, and here he is quoted, "My lower jaw is forward and to the right. My back teeth don't touch. It affects my speech, chewing. I bite my tongue. My jaw gets tired after talking or chewing." In a few sentences' time, his muscles are fatigued and he has to pause to talk again. And he can't chew his food straight through to swallow it. He has to pause. He has too much pain trying to chew his food, which translates to he'll have something very soft, because if it requires any amount of chewing, he's automatically in discomfort. Well, maxillary development, when there's no crowding and significant symptoms in the head and neck, is going to mean a lot of jaw growth and development, so we open up a whole chamber. Now, if you hadn't counted in the first place, he has all 32 teeth, just narrow and trapped. So narrow and trapped is a jaw or foundation issue. Just because he had 32 teeth didn't mean he grew appropriately. They just happened to be there. So we're going to open him up for an entire new tooth. And in opening all that up, back teeth wider, front teeth forward, I can build him a cute little ceramic bonded bridge. And that's all that is, a Maryland bridge. He wasn't ready for the expense of the implant dentistry. But here we have a ceramic Maryland-style bonded bridge, prepless, so he's not been violated. I can remove that at any time and have the normal, pristine teeth that he had. But meanwhile, the lower teeth are upright and away from the tongue, so now his tongue has more room. You can see the whole ridge. We don't have teeth that have excess lingual inclination. That's a bad thing for a human being. Excess lingual inclination. That's usually the foundation is a problem. Open it all up, and we have just a little bit of overbite and overjet. All of that growth, wider and forward in the upper jaw, and the lower jaw didn't stay where it was. It followed him forward. And as we watched that upper travel, you know what the lower did from edge to edge? It stayed edge to edge for over a year until the upper got finally far enough to go. That's almost 6 millimeters of forward travel in the upper without having an overjet increase. That's how far the mandible was trapped back by being narrow, and that's where his facial pain came from. Now he has total relief. And here he is. Now, I added those 2 premolars. Remember the picture up here? I added the 2 extra premolars. He has 34 teeth. But other than that, it's whitening gel. It's not a set of veneers. It's not veneers. He has 1 added tooth. And the 1 added tooth is right behind the canine. Everything else is his own. He's just a tooth whitening addict now. Yep. So a broad, wide foundation, coordinate the teeth, and he is totally asymptomatic. He can chew whatever he wants for as long as he wants. He doesn't bite his tongue anymore. He can talk for as long as he wants without getting tired. And that now is also his wife's chief complaint. So I had to sell her duct tape. Just turn it into profit. I'm sorry, that's bad to say. How about the profile? This is without elastics. This is without any type of expansion appliances. Phenomenally, I only used clear aligners on that case. So it was clear aligners alone did this. Lip seal at rest, nasal breathing, sleeps beautifully. He's 5 years post-treatment. So we're 5.5 years without a single symptom, none. None of the patients you saw today, along with none of the other thousands that I've treated in 18 years, wear a night guard or a splint or an orthotic. I don't have a single patient in a night guard, a splint, an orthopedic appliance, nothing when they're sleeping. Nothing. I don't have a patient in the TMD category that has a residual symptom, not one. And the last 9 years, I've had the opportunity to treat the most severe TMD symptom list you could imagine, including vertigo, to the point where this nice lady could not get out of bed without collapsing, lost her job as a teacher, lost her house, the mortgage, and then had a 2-year spiral out of control, and then we met her. After treating her, the vertigo went away. Got her job back, got her house back, the whole thing. Totally normal life. She comes in, gets her teeth cleaned, and says, "You should be proud of having helped me. You changed my life." This guy can't believe that this happened to him because him, like other patients, you know where they end up? Other consultations. They don't meet me first. They meet me last. 4, 5, 6, 7, 10, they come in. "Oh, I was told I have to take out teeth. I was told I have to do jaw surgery. I was told I have to do this." I have a non-surgical technique. We don't do surgery on any of these patients. Do I have 3 patients in the last 18 years that had jaw surgery? Yes, they were all within the last 5. I have 3 patients in the last 5 years. They all fell in the severe obstructive sleep apnea case, a diagnosis, and with severe OSA, with life-altering and life-debilitating symptoms, one of them uncontrolled blood pressure at age 50, and then another one had such a severe issue with the breathing, he couldn't sleep more than 1 hour. And so when you're sleeping 1 hour at a time and you're 26 years old, you're in a bad place. Basically, the 3 people that I guided to MMA, maxillomandibular advancement surgery, we pre-treat them because you still have to deliver the width and coordinate for the surgery. Then they get the surgery to go forward to get that stirring straw to be a garden hose. And then, of course, they come out of that and 24 hours later have regulation of the blood pressure, off blood pressure medications. All of the symptoms fade away. They go to sleep. They sleep through the night. They dream all night long. Everything heals. So I do have 3 people that ended up in a surgery category. But usually I reserve that for severe OSA when you have a list of symptoms that is just debilitating, and I can't get ahead of that. All of these patients have been treated non-surgically, and most of them with removable techniques, except for the couple of kids where I told you in there I had fixed expanders to kind of get them caught up. So the difference between unhealthy, struggling, and thriving has to do with jaw growth and development, so you can then become a nasal breather. With nasal breathing, you sleep through the night and have a beautiful sleep cycle. With a beautiful sleep cycle, you wake up refreshed, your brain gets to do its job. But the moment you're not nasal breathing and you're mouth breathing at night, your brain can't do its job. It has to redirect itself to fix your breathing. And when the brain redirects itself to fix your breathing or improve your breathing, it's basically controlled by the sympathetic nervous system. So the reason we have so much trouble is sympathetic nervous system activation at night is unhealthy, even though the body's trying to fix something. It's a fight or flight reaction. Nasal airflow resistance, mouth breathing, or worse can trigger the sympathetic nervous system. And once that's activated, parasympathetic gets shut off. And then the whole thing about rest and digest is in a state of collapse. And now the human being will struggle because of the sleep fragmentation. And sleep fragmentation every night with sympathetic activation every night is a strain on anybody's system. That's an inflammatory cascade that goes from night to week to month to year to decades. Decades of damage being done. So we don't address the teeth. I know they all look nice. Everybody had a nice smile, but the attention was on the foundation. We grow the foundation, then we coordinate the teeth. Foundation first, teeth second. Part of growing and coordinating the foundation is that you transfer your human being that you're treating from a mouth breathing or worse to nasal breathing. You have to become an obligate nasal breathing human being. So the number one item on our checklist is establish nasal breathing. That's the number one item. So while we're doing growth and development, the primary outcome is a nasal breather. That's our primary goal. Now our secondary goal from the jaw growth and development is the tongue. The tongue is the second most important part in there. You've got the nose doing the breathing and the tongue strengthened and functioning appropriately. That means myofunctional therapy. You don't get to have this type of result without working with myofunctional therapy. It's called orofacial myofunctional therapy. This crowd's probably heard of those words. Some dental meetings I end up at, they don't even know what that is, have never heard it, doesn't know it exists. Meanwhile, it's probably the single biggest thing that can help a human being is the myofunctional therapy. So we should have a lot more of them helping our patients. I'm fortunate I have them nearby me. So I'll leave you with this. It is evident that the next great step in medical progress in the line of preventive medicine should be made by the dentists. The question is, will they do it? Look who said that, Dr. Charles Mayo. Dr. Mayo, you know the Mayo Clinic. Yeah. Well, we'll tie a couple things together here. While Dr. Mayo is very prestigious and the Mayo Clinic is very prestigious, what does the medical community know about the mouth? You don't have to answer out loud. You don't have to answer out loud. The dental community understands that the medical community does wonderful things and we love them. We love our doctors. But the idea that the medical community knows about the mouth, it's not. Guess what? Dentistry is its own specialty. Dentistry was pulled from medicine. So the medical doctor, the medical field doesn't really know about the mouth so much. But the dental community does. So I'm no genius, but I think this guy said this before 1939. That's 80 years ago. It's 82 years ago. What is dentistry waiting for? So in my world, dentistry transitions. It transitions from the teeth as a focus to the jaws as a focus. Pay attention to the jaws. The teeth will go where they should go. It's amazing. If you go after the jaw growth and development, the breathing and the musculature, your teeth will look amazing. So the title was Airway Dentistry. What I do for Airway Dentistry is growth and development. Preventative, yep, I'll add to preventative, I'll say curative. Because a lot of these kids come in and they have symptoms. I meet almost no one who sits down and we go through checklist after checklist after checklist and they're totally asymptomatic. I meet almost no one. I know it's inappropriate for me to say all, never, none, always. That's bad to say when you're on a stage. So I'll say almost. Almost no one comes in, and it doesn't matter the age, where they're totally asymptomatic and healthy. I see a lot of unhealthy. I diagnose a lot of unhealthy. And where's it all come from? The jaw growth and development. So jaw growth and development, nasal breathing, proper tongue function and strength, that does involve the frenum releases. You will have to get involved with frenum releases to have this kind of an impact. If you want to take an unhealthy human being to healthy, you learn how to diagnose a tight frenum, and then you learn either how to or where to refer to have it released appropriately with myofunctional therapy. It doesn't get released on its own, it gets released with therapy. So, jaw growth and development, and then the teeth second. So I would hope that somewhere along the lines, dentistry will swing its attention from the teeth to the foundation. And that's how you get a healthy human being. Not to minimize crowns and bridges and implants and all the good reconstructive. I did reconstructive dentistry for 10 years before I switched to this. Now I don't do reconstructive dentistry because I don't see the teeth anymore, so to speak. I just work on the jaw growth and development. But people still need restorative dentistry. I don't mind doing restorative dentistry. I do it occasionally. But it shouldn't be the focus anymore because fixing the teeth doesn't make a human being healthy. Fixing the teeth doesn't make a human being healthy. Fixing the jaw growth and development, establishing nasal breathing, proper tongue function and strength, all of a sudden you get a healthy human being. Then guess what? You can still fix the teeth. Last, All right, that's all I have for you. Thank you very much for your time and attention.